Welcome to this last module on bifurcation and left main treatment organized by Goran Stankovic. As you know, it's a continuum. There was before that 5 modules. One, when and how to perform a provisional cyber stenting, understand the role of imaging, tips and tricks for culotte stenting, decay crush, high bleeding risk patients. And today we'll have a learning webinar on distal left main PCI from Clinique Pasteur with Jean Fajadet and Bruno Farah. So let me present the case. Of course, I have with me Edem, who will help me to answer to the question that we'll have from you. So this is the title, PCI of left main LED lesion with dominant circ. You will see the images. The patient is 68 years old, male patient, relatively small size, 162 centimeters, with 3 risk factors: hypertension, dyslipidemia, and diabetes mellitus on insulin therapy. The patient had angina class 2. The clinical examination is normal. Is in a sinus rhythm with normal EKG, and transthoracic echo showed the normal left ventricular ejection fraction, no valvular disease. The patient had a CT scan before the coronary angiogram, which showed some left main and LAD disease. The biology of the patient is without any abnormalities except hemoglobin HbA1c, which is 6.7%, so close to a very acceptable level. CRP is nearly normal. Next. So this is a summary of the coronary angiogram which was done. You can see a lesion of the mid left main, which include also the proximal part of the left main. There is also some LAD disease that we will see in the next slide. So you can see now the disease of the mid part of the left main and disease of the proximal LAD. Next. And you can see in this view that there is some disease also more distally at the level of bifurcation with diagonal, but which seems not to be significant. Next. And in the spider view, you can see that this lesion of the proximal LAD is including the ostial LAD. So it's really a bifurcation lesion. In lateral view, you see that we have a dominant circ and this disease of this long LAD. And the next slide will show you the right coronary artery, which is a non-dominant vessel. Next. So if you summarize the risk evaluation of this patient, Euroscore is 1.6, Eurocos 2 1.1, STS score 1.3, the syntax score, which assesses the complexity of the lesion, is 21. So if you make the calculation of syntax score 2, you can see that the risk of 4 years mortality for PCI is 3.7 and for CABG is 7.3. So according to all this data, the decision of the art team was to do a PCI. Next one. So the key objective of this live case is to treat this 110 left main bifurcation lesion according to Medina with a dominant circ, and you have seen that this vessel is large, using a provisional side branch stenting approach. So of course this is open to discussion, and we are waiting for your question. And while you are making some question, we can show the angiogram, which was already done by Jean Fajadet and Bruno Farah. You can see clearly that this circ, which is a very big vessel, at least 4.0, and this lesion of the mid left main and proximal LAD. which is seen clearly here. And maybe you have a spider view. Yes, so spider view show exactly the same. So this lesion is up to the ostium of the left main. We can see also that there is some calcification of this distal left main and proximal LAD. So maybe we can move to the CAS lab and ask Jean and Bruno which kind of strategy will they apply to this complex case. Jean?
Monsieur?
So, hello
Bruno?
Thierry. We are very pleased to welcome you in the Clinic Pasteur Cat Lab. So it's quite an interesting case because it's a 110 bifurcation distal left main, as you mentioned, with the specificity of this large dominant left circumflex, which has no disease at the beginning.
Yeah.
Jean. That's the main, I think, issue and discussion here. So the strategy, I think that we will treat left main LAD first. So pre-dilatation, procedural stent, and there will be the discussion of the size of the stent because we have to be in accordance with this large circumflex, which diameter we should achieve at the level of left main, and maybe it will be maybe a discussion of the size, the diameter of the stent we want to take. We have to take to achieve this large diameter in the left main. Then second step will be to the pot. And I think that for this large left main, due to the left circumflex dominance, we have to use at least a 50 millimeter balloon. Then after doing this spot, we will see reopening the struts toward the circumflex because it's a large circumflex, and see if this proximal strategy is enough or if we should move to a two-stent strategy. This is the plan A, I will say, and maybe we have to change during the case, and maybe we are waiting for your comments and discussion.
Okay, so thank you very much. I think this is a very good plan. I see that you are coming from the radial approach. So which kind of guiding catheter you are using, which kind of wires, and which kind of balloon for pre-dilatation? Because we have seen in these last images that there is some calcification of the proximal LAD and distal left main.
Yeah, sure. And so Thierry, then you see here it's a 7 French XB 3.5 guiding catheter. So we are coming from the right radial artery. After placing a 7 French sheath, we have engaged the left main ostium with this XB 3.5 guiding. We hesitate at the beginning between the 3.5 and the 3.75. At present time, it's not too bad. And we will see during the manipulation of the wires, balloon, if we can get a better, coaxial alignment of the guiding catheter to the circumflex. But typically, you could see here this really, really particular anatomy with the large size, a large artery, the circumflex artery. And here you could see that the diameter of the proximal circ is larger than the diameter of the left main, which is not, of course, true. And this is interesting to see, first this view, and second, here the spider view, to see the difference in diameter between the two vessels, the circumflex, which is a large dominant artery, and the LAD, which is diffusely disease, with some calcification in a proximal segment, and this significant lesion on the proximal segment. So the technique, the strategy that we have selected, but again, everything could be discussed. It's to try to have a provisional stenting strategy, placing a stent from the left main to LAD after pre-dilatation. And then we could discuss later the size of the balloon for the pre-dilatation. And after placing the stent in the left main LAD, we will do a pot, a post-dilatation in proximal. After that, we will advance certainly a third wire to cross the struts and of the stent, place this third wire in the distal LCX, and then open the struts with quite a large balloon. When you see the size of this vessel, should be around 3.5 maybe. And then after that, we will do the kissing balloon technique with a larger balloon in the circumflex and the smaller balloon in the LAD. So it could be 3530 or 4035. We could see the according to the angios during the procedure. And finally, we will finish with the final pot. Could be 4.5 or 5 millimeter balloon. And we will discuss then the need for intravascular imaging to assess the quality of the result, particularly the complete apposition of the stent, particularly at the side of the circumflex and the left main. So this is our strategy: 7 French, provisional stenting, and kissing balloon, pot before kissing, repot, and after the final pot, you will see. So I think that this strategy is summarized on the slide that you can see now. Again, it's a particular anatomy, and that's the reason why, because we select the 7 French access because of the huge size of the balloon that we will use. It could be done, performed with a 6 French guiding, but again, we will have a measure, resistance, friction.
The balloon, it could be more difficult. We will
it's
be
what
more
we think.
comfortable. I think in terms of comfort,
we will be more
French,
comfortable with the 7.
And it's a big guy, he can accept a 7 French sheath, a 7 French guiding catheter, so it was not an issue here to use a 7 French.
Okay.
Yeah, I think it looks like a very good strategy, Jean and Bruno. 7 French, I think is necessary because with 6 French it will be very difficult to manage the 2 balloons with kissing balloon. I think 3.5 was a very good compromise because there is disease nearly up to the ostium of the left main. So with 3.5 you are not touching too much the disease of the left main, and you have a correct support. Of course, it's not perfect, but I think it's a very good compromise.
Okay.
So we follow you. I think it will be a very interesting and a very learning case. So now you are using 2 wires.
The wire is a BMW, I think.
Yeah, this is a standard BMW that we use in routine. So the first wire could be parked in the distal circumflex here.
Okay.
Then we will advance a second wire in order to place this wire in the distal LAD. So this is the circumflex wire.
Okay.
So do not hesitate, according to the different questions are coming.
Of course, yes.
Where you could take the lead and.
Jean, can you explain the shape of the wire that you have done? Because I've seen that you have.
So if we can zoom on my hand.
Yeah. So the same for the LED?
It's quite similar.
Okay.
Quite similar. This is the type of shape. Zoom encore on the wire. Zoom à fond.
So you have a short angle distally and then a relatively long one.
Yeah, we have in fact two angles, a short one and another one. It's what I use now more and more when we have bifurcation or the tortuosity to negotiate with the wire.
And we have seen that it was very easy to access toward the circ without any...
The circ was easy, yeah. Maybe what you can do is to place to take this view.
You want to find a view?
Yeah, 50 by LAO by 32, 51 by 32 caudal. So
okay,
and so we are arriving here.
So Jean, what we will do is to ask the audience if they are okay with the plan. We can ask them to vote. So everybody agree with this strategy proposed by Jean Fajadet? So click on green if you agree or red if you do not agree. And of course, if you do not agree, please
Do not
tell
hesitate. Yeah.
us what
Yeah.
what do you propose. Okay.
You can, because we discussed a lot
Yeah, you would
before taking the decision.
Yeah.
We discussed a lot. There was a different possibility. There was a possibility to do a two-stent strategy,
I see
placing a
here,
large stent from LAD LCX, and
Yeah.
then do a tap to the LAD, or the opposite.
I have
So I advance slowly.
100% of person
Yeah.
who
Whoop.
is agree with the strategy.
Yeah.
So that's good
So
for the
everybody
moment.
agree with the
Everybody
strategy
agree
at
with
that
the
time.
strategy.
Test. Je
On a
suis sur
petit-
la.
Non, peut-être pas.
Okay.
J'ai l'impression que je suis latéral. Ah no, it's okay. It's okay.
okay.
So I was thinking that I was in the lateral,
Maybe we can move in the.
artery, and
I
now
think
we
it's
have to
okay.
avoid the diagonal. It's a lot of, feeling of resistance, of
It's
calcification.
calcifications. That's why it's important. I think that's
yeah.
something what was mentioned by Thierry from the beginning. That
Yeah.
there was some calcification.
Not easy.
And
Not easy to advance the. We will try, but we will see.
You
So
want to
now
go?
in the diagonal, but it should be better to move to the cranial view in order to now to negotiate this
Yeah,
bifurcation.
I think it's a
So
very
I pull
important
back.
point, Jean, to have the view according to where you are in
Yeah.
the vessel. And
Just-
now it's
It could be more simple, but we will see. I'm not sure, but okay,
Okay.
here we
yeah,
are.
yeah, it is.
So another one.
So Jean, according to the feeling that you have,
Yeah.
which kind of balloon you will select for pre-dilatation of this LED?
That's a good question. That's what do you think, Bruno? Kind
Well,
of balloon. First, the type of balloon,
Yeah.
semi-compliant or NC balloon,
Yeah.
and second, the size.
I think that because it's a quite, a calcified lesion, you have some resistance. Maybe I will start with a non-compliant balloon, a
Yeah.
3.5 non-compliant balloon. I think it would be a good
Test.
compromise. You can work on the pressure and limit the risk of distal dissection because there is a long disease on the
What treatment?
LAD.
2.5?
No, 3.5.
3.5.
3.5.
Not too large for the distal.
I think that it's okay. I think for the proximal LAD.
What do you think, Thierry?
I think it's up to you. Personally,
I was thinking to the 3.0,
3.0,
but
okay.
Me too.
but again, at the end, I think we will finish with the 3.5. Sure. Because there is a very few LED smaller than 3.5, proximal LED. But this is a particular anatomy. But anyway, okay.
No,
Now we
the
are. I
advantage
think
of
we are in test.
3.0 is that you non-compliant, you will be able to go to very high pressure if you see a waste
Yeah.
of the balloon. So I think it
Okay.
would be
What we call
more-
3.5, 3.0. What do you think?
3.0. 3.0. It's
up
okay. I
to
think
you,
in terms of safety, I think I agree with you that 3.0 is okay.
NC balloon or
3.0 NC.
NC?
Yeah. 3.0 non compliant.
20? Yes.
20.
We can take a 20 because we inflate from the left main to LAD. Okay. So 3.0 NC 20 by 20 millimeter in length from the left main to LAD. And it should be interesting to see what level of pressure we need to open the artery.
Absolutely.
It looks calcified, really. But the feeling that we have with the wire.
So Bruno, in terms of anticoagulation, what is your strategy for this kind of case?
So this patient have been prepared by DAPT. It's quite stable because it's a silent ischemia. I will say that. So it's a standard protocol using aspirin and clopidogrel, and we inject just before the procedure 1,100 units per kilo. That is, we inject 9,000 units of heparin.
Okay, I pull a little bit the balloon because it was too distal. Here is not too bad, but you can see before injection the calcification on the lower parts of the vessel.
Okay, I inflate.
Yeah, we could see it.
No, it's a nice opening.
Yeah.
How is the
So
pressure?
20.
It's 20. Yeah.
Because for me, I went directly to Sweden.
It's 20 atmosphere. Yeah.
Yeah. There is a small
And
waste at the ostium.
yes.
Very small one.
Yeah, that's true.
I deflate after.
We could see the
So do you have a good tolerance
with
of
the
inflation?
zoom.
Yeah, the
could see
pressure
the-
was quite stable during the inflation. It's quite not a very long inflation. There was some ST modification at the end of the inflation, but
You see
the hemodynamic tolerance was quite good.
Okay.
You see the
As you said,
the balloon on the inferior part of the balloon.
Yeah.
There is some residual narrowing. Yeah.
Yeah.
We will see. Take a
But
picture
I
of
think
that.
it's very acceptable.
Yeah. Okay. We take a picture and we will see. It's better on the LED, but of course the left main.
You see, there is a quite long
we
disease.
need a larger.
Yeah.
Yeah, absolutely.
Yeah.
What do you want? Another one or? You
Jean,
inflate 20.
20, yeah. So
20, I think, is
the
enough.
question
So-
is now, do we have to take a 3.5 or are we satisfied with this pre-dilatation and move
And the length.
and the length?
You see we can calculate the length. Look at this is 20. I suppose it's at least 28.
Yeah.
Do we need to go to 30, 33? So what you can do is to measure
with the
again
balloon.
with the balloon.
Maybe
In other
using-
words, place the balloon here in the LED test.
Okay.
So the stent test will arrive here, something like that. And
And
now
then-
move to the caudal to see. Yes?
Jean, I see a stenosis before the first diagonal. You want to
Yeah.
pre-dilate this lesion, or you?
We will try to, you see, place the distal end of the stent at the distal, at the zone of the level of the
Yeah.
distal marker of the balloon. This is interesting because when we look, this is 20, so we need at least 28.
And
I
even
will say
more.
maybe 33. What do you think?
33 or even
Or 38?
what the
Because we have to
Yeah.
start from the ostium. Eh?
Yeah.
I think it's better. What do you think, Thierry? In this particular case, you will start from the ostium for the stent, the ostium
yes,
of the left
yes,
main.
Yeah, because there was a lot of disease at the proximal part of the left main. Maybe you have some safe zone, the first 3 or 4 millimeters of this left main.
But anyway, yeah.
The big discussion is the length of the stent, so 33 or 38.
What do you think?
Yeah. I would say like this, for me, difficult because we don't see exactly what length we need between the ostium of the left main and the distal left main. I think 38 should be, in terms of length, the most simple. But if we use a 38, we may touch the second lesion of the middle AD.
Exactly.
33 could be good to avoid to touch the middle AD, but could be short for the left main. So
we
that's
could
the difficulty.
see in this view to see the ostium of the left main.
You see,
we have
we are a little bit too low here, I think.
Yeah, but we have at least 10 millimeter, 12 millimeter proximal.
Yeah.
So
33 should be okay.
33 should be okay.
Jean, what you can do also is to use a wire to measure the length.
Yeah.
Sure. With another one.
But take care because you remove the wire.
I'm removing the wire. Yeah, I see.
You can use a third wire to just be sure that 33 will be okay.
Okay, we can do that.
Okay.
So with the radio opaque part of the wire that is 30 millimeter, it should be. It's a good.
We can do that. That's a good advice. Because you see, when you are not sure, it's better to try to measure with the wire. So it could be certainly a 3533, but we are donné le troisième guide. We are measuring with the wire.
Maybe we can go back in this view.
Yeah, in this cranial view, you have a very good view of the ostium of the left main.
Yeah.
So I think it will be nice to check in this view.
So you make the same curve?
Yeah, a little bit like that, not too much, in order to the goal is to place just the distality through the. So if you can
Sorry.
center, no problem. We are here.
Okay, I put it some.
That's good.
New
Yeah, thank you. And we will advance the third wire in order to measure and to appreciate if we need something which is longer than the 13 millimeter or okay, we are.
It's a small branch.
That's a small branch.
In the beginning.
Yeah.
The same, I
From
think.
the beginning. Yeah.
If we have difficulty, we'll go back in the spider view.
Yeah. Could be. Tu me mets le torqueur, t'attends. Hop. Merci.
So what is nice with the spider view in this case is that we can see clearly the bifurcation and the carina. So it can be helpful
we can remove this one.
When you will have to go through the distal strut, for example. This view is really perfect.
Okay, it's not easy. Huh? Maybe with the loop. Okay, with the loop is okay. Now we deploy the loop and now we will see.
Yeah.
Okay, here 30. Now we come back to the cranial. Maybe 33 should be enough. What do you think?
Yeah, probably, yes.
Cranial first in caudal to see it here. Ready? What I can do is to disengage a little bit the guiding. I have the possibility because I have the free wires. So if I push on the wire here with my right hand, you see, I will disengage like that, the guiding catheter. In the same time, Bruno can do the angio. Okay.
But now you advance the wire.
Yeah, but now I will remove it. I push on the two wires and I will remove the third one.
Perfect.
This is 30.
Thank you.
Which is 30. So again, I will push on the two first wire, distal. I disengage the guiding from the left main. And now, maintaining this, I will advance the third one. Picture? Oh, I think 33 should be okay.
Yeah,
what do you think?
Absolutely.
I think so, yeah. I think so.
33?
Yeah.
You agree?
Yeah.
Okay.
Absolutely.
Okay, we remove the wire. And now, 35, 33 on the LED wire.
You will cover the ostium of left main or not?
Yeah.
This
we will
the
cover
plan.
the ostium of left main. It's what Thierry proposed. Bruno also proposed. I think we have the three of us the same position for that. I think it's better. Of course, what we have to avoid is to place the stent too proximal. And what we have to avoid to have a stent a little bit, swimming, diving and swimming in the aorta. So now I will, this is the lady wire.
Yeah. So this is now we have done the pre-dilatation. We have selected the stent. It's a 3.533 millimeter DS. So we will implant the stent from the ostium of the left main toward the proximal LAD.
So Bruno, can you explain why you selected the 3.5? Because the vessel is a little bit more than 3.0.
Yeah, I think that here we have to remember that what we want to achieve is at least a 50 millimeter diameter inside the left main. So it's a very important point here.
Yeah.
And we have to take care of that. We have to choose the stent diameter in accordance of this final diameter we want to achieve inside the left main. So probably we are a little bit oversized if we consider the LAD, which is close to 3.2. But we need to have a 3.5 because we know that the 3.5 DS actually are able to get up to 50 diameter. If we choose a 30 millimeter diameter, which is okay for the proximal LAD maybe, we never could achieve a 50 millimeter diameter inside the left main. And that's an important, I think, technical point. Select always the diameter of the stents in accordance of the final diameter you want to achieve inside the left main.
Yeah, I think it's a very important point. And of course, you will deploy the stent at low pressure, not to be oversized. And at the end, you will be able to impact correctly the stent if needed. But it's very important for the audience to remind that the 3.0 stent is the same as the 2.25. So the only difference is the balloon. So if you want to really have a good
Too
scaffolding,
proximal.
Yeah. So now we are trying to put the stent at the level of the
Yeah.
osteums. That's a very important step of the procedure, I
Yeah.
think. And we have to explain that we are in general in a LAO projection
Yeah.
in order to see the separation between the ascending aorta and the ostium of the left main. Sometimes we have to find the correct view. It's LAO 40, LAO
Yeah.
30. It
In this
depends.
particular case, it was LAO 29. Here we
Yes,
are in
perfect.
the LAO 31. We will see. Sometimes it takes different injection, few injection to be
Yeah.
sure that we have really the best view in order to place the proximal marker just at the or the stent of the balloon of the stent just at the ostium. So
This
you
is-
see, this is not too
Yeah.
bad.
Yeah.
What is important is in this view, what we need is to look at the upper part of the left main. In other words, the goal is to cover and to scaffold the upper part of the roof of the left main. In this particular situation, there is no problem for the inferior part. But for the upper part, I'm not sure that maybe we need to, you see, we need to have back a little bit.
We are very close because
We are very close.
because remember that the stent
the
is
marker
inside the
is
marker. So
that's very important. And really, at that point, we have to take time to be sure that the stent is really well placed. And in other words, the goal is to place the proximal marker of the balloon just inside the aorta in order to be sure that the roof of the left main will be covered. But of course, not too much because we will have too much stent inside the aorta. This is not too bad. What do you think?
yeah.
In my opinion, it's perfect. You have a perfect view. You have a good positioning.
Maybe a little test, one more.
Okay, I will test.
And
Sorry.
this really, we need to take time.
course.
No hurry to do that because when the stent is delivered, it's delivered. You cannot change the position. So this is too proximal, and this is too proximal for life. So we need to take time. Go on. Maybe too proximal here. What do you think?
Yeah.
To advance a little bit, 1 millimeter. Test one more time. Here is better.
Yeah.
Okay,
better.
go on. 6.
So we can accept 1 to 3 millimeter to stent protruding.
Not too bad.
Yeah.
You see?
Or not?
In fact, the plan is not to protrude in the aorta. The plan is to cover the upper part of the left main.
Yeah, exactly.
And
Like
because
that.
the left main is not perpendicular to the aorta,
Yeah.
the lower part will be protruding a little bit.
Stop. On va tirer.
Because it's not perpendicular.
Okay, so now we have delivered the stent.
At quite low pressure.
Low pressure in order to avoid distal,
dissection.
dissection. And so what we will do now is to pull back the balloon inside the aorta, and now we are sure that I think it's okay. And now Bruno can take a high pressure, 18, 20 atmosphere, because we know that the distality of the balloon, the distal marker, is within the stent. So the risk of dissection is close to zero now. Okay. So now, deflation of the balloon.
So Jean, can you make a stent boost, for example, to show?
Yeah, we can take a stent V's here, a little bit cranial, and in the same time we could use the stent V's.
Yeah.
Yeah.
I will show you. We will show you. Yeah.
The stent is well.
Stent V's is possible.
Yeah.
Attendez, il faut qu'il y ait. Il y a toujours la.
Okay, we will do it.
Okay.
On peut faire. Okay. So we will soon look at the distality of the stent.
Okay.
You see,
It's good.
Montrer le
looks
stent
like
vis.
very nice.
Yeah.
Yeah.
So maybe I pull a little bit too much the
but-
balloon, but it's not a problem because we will come back for the post-dilatation.
Yeah,
Yeah.
of course.
Okay.
Of course.
But we see the difference in size between the osteum of the lady and the first millimeter of the lady and the distality of the stent. You see, we have a conic shape of the stent. And this is due to the two-step inflation of the stent, the first at low pressure, and then we deflate the balloon, and then we pull the balloon inside the stent, and Bruno took at that time 20 atmosphere. And this give you this kind of shape, conic shape of the stent.
Absolutely.
So now, Bruno, next step.
Next step, we now
remove this one.
We remove this one. Next step, will we do the pot now, or
The pot.
Or do you want to go back with a 3.5?
Maybe a 3.5 NC balloon.
Yeah. Maybe we can check also the distal part of the stent to be sure there is no dissection beyond the stent, because we have this plaque in the middle AD, and it was maybe something that we have to survey.
Whoop.
Carefully.
Yeah.
So probably
Jean,
we have to check.
Jean, can you explain also how you control the guiding catheter to avoid the longitudinal compression of the stent?
Yeah. So what we do all the time, we push on the wire, and particularly the LCX wire, in order to avoid, and particularly when we remove the balloon from distality to the catheter, the risk is to have the balloon diving inside the stent, and because we have a jailed wire, we could have the problem at the ostium, and the risk is to damage the proximal end of the stent. Yeah. So all the time, keep the guiding catheter a little bit outside using this LCX balloon. Okay, here now we can take a view just to see angiographically how is it. It's not too bad. Yeah. What you can do maybe is to take a cranial to see if there is no dissection distal to the stent. So in cranial view and maybe areocranial. This one is good.
Yeah.
We go?
Take some contrast.
Take some contrast, sorry.
Okay.
And Bruno is injecting now? It's perfect.
I think the position...
Okay, this is good. The position of the distal end of the stent is the plan. It's proximal to the plaque, which is at the level of the diagonal branch. So the distal end is a little bit proximal to the plaque. We deliver the stent at low pressure. We inflate the balloon inside the stent at high pressure. And now we will come back with a 3.5 NC balloon, really to take high pressure. It could be 12
or 20.
12 or 20. 20 is NC balloon, yeah.
20.
So Jean,
there is some spasm on the middle AD, distal middle.
The objective of this 3.5 NC balloon is just to finalize a position of the stent in the proximal AD.
Yeah, exactly.
Yeah, okay.
And then we will come back with at least 4.5 for the proximal pot inflation.
What is very interesting is that we have seen on the stent boost or stent vis that you had a different size also in the left main. So the left main, the stent in the left main is a little bit larger than in the LAD, just because there is no resistance to oppose to the stent, because the vessel is at least 4.5.
Maybe the best is go in caudal view, no?
Yeah, we can go caudal. The caudal was good. Here is okay here, you see. What you can do is to just take without contrast, just
I think it's okay.
Now contrast. We can advance a little bit more distal, like that. Okay, here is okay. No, just 14, and then we will fall back at 20, 22, 23. 14, 16. Okay, good. And now a little bit more proximal. Here.
Here we can go.
And now 20, 22 atmosphere. Okay. We could see the calcification distal to the stent. It's a distal plaque distal to the stent here. Yeah. Okay, here we are for the LAD. And now we will do the same for the
So
left
when
main.
you remove the balloon here, it's a non-compliant balloon. You take care not to have the guiding diving.
Exactly. And so you see, if you zoom on my finger, you see that between these two fingers, the thumb and the index here, I push here between the two fingers, I push doing that movement, the two wire distal. And in the same time, with this end, I will remove here the balloon. And I maintain the two wire distal. And all the time I follow this maneuver under fluoroscopy in order to be sure that the guiding is not diving and damaging the osteum of the stent. Okay, now this balloon is out.
This is a very important point. We call that the left hand control in my lab, but we are doing exactly the same. So I think it's very important because, as you know, in Excel there was 7% of logistical compression.
That's a problem.
And this was associated with MACE rate, which was doubled as compared to patients who had no longitudinal compression. So it's very important.
And that's a problem of the multi-center randomized trial. Compare sometimes with a single center study report, because this kind of small really details have a major impact on the clinical outcome. That's a problem.
Absolutely.
I have to be sure that all the procedures are performed with this kind of what we call minutious.
I think it's minutious. It
Everything
takes
is in the
longer
details.
time, but it's very important. Sometimes we want to go quick. You have inflated the balloon inside the left main, so you want to remove it quickly because you say that, okay, we have to let the left main breathe.
Sure.
And sometimes it's an error, and because we have to be very cautious when we remove the balloon, when we advance the balloon also. When you advance a large non-compliant balloon, we have to do it very gently. Do not force if we have any resistance. Maybe change the coaxiality of the guiding. But it's all these little steps are very important in terms of the long-term result.
4.7, ça peut être 12, pardon, 12. So now we will take the balloon for the pot. What do you think? We take first 4.5?
Yeah.
So Jean, will you use semi-compliant or non-compliant?
This one is non-compliant.
Yeah.
Okay. So I think it's really open. Personally, I will use a 4.5 semi-compliant because you can use the compliance of the balloon to increase the size if necessary. But 4.5 is a very safe NC balloon. It's very safe. So I think,
but when you look at the size of the circumflex, which is at least 4.0.
I think we have to finish with a 5.0 for me.
And 3.5 in LAD.
I agree.
So at the end, we will finish certainly with a 5 millimeter balloon. But at present time, maybe we could do step by step.
Absolutely.
In order to not be too aggressive for the first time. So here
you advance very. Okay, you see, sometimes there is some resistance.
Yeah, I hope that we are on the right wire. Yeah.
Yeah, I think so.
Yeah, you are.
Yeah, I think so.
It's just the fact that because you remove the guiding, you are no more coaxial.
Yeah.
So you have to change a little bit now the coaxiality.
And maybe I was. This is interesting. It's negative.
Yeah.
It's a non-compliant. This is one of the.
Yeah, that's a problem. Huh?
Limitation of non-compliance.
You see, NC balloon.
Sometimes you.
Maybe if I cannot, I don't want to be too aggressive. We will take
4.0
a 4 pi or 4.5, but semi-compliant. The.
Okay, we don't. It's important not, going.
Okay. Donnez-moi un 4.5.
So interesting. We have to talk to the audience because we had the problem of connection, so we had no questions since the beginning.
Okay.
But now it's back.
Okay.
So all people they may ask a question as they want.
We have a flow of questions now.
So Edem, now be ready for the question. Huh?
Yes, I'm ready.
But I think we had a very nice demonstration with a very interesting case, a lot of technical details, which I think are very important for treating this kind of lesion. would add something about that is that the deflation time of the balloon is very long. So people
Yeah,
wait for 3 seconds and then they pull back. But in fact, it
that's true.
takes 10 to 15, sometimes 20 seconds to have a fully deflated
Yeah.
balloon. So it's very important to take time. And the same for inflation. Time is your friend. So take time to
Interesting.
inflate, take time to
Okay.
deflate.
You see the difference
Yeah,
between the semi-compliant and the non-compliant test?
absolutely.
Yeah.
Okay.
Okay, so we can
non-compliant balloon
maybe we can go
cannot
to
cross,
the
we can
spider view
change
just to see the
semi-compliant
zone of the
can easy
bifurcation.
cross,
Yeah, because the non-compliant
Which
balloon
view
is
you
very
want?
No,
distal
the
part
spider
is very
view.
stiff.
Yes.
More,
So,
just to see
so that's why
the
sometimes it's very
bifurcation.
difficult to come back with
I
this
want to avoid to be too
large
distal test.
4.5.
It's okay here.
It's okay. You can.
Okay, we can.
Here.
I
Yeah,
think
you are,
so.
you are in a
I
good
think we are.
position for a
Yeah.
good pot.
So now you see the 4.5. It's quite large, you know.
Semi-compliant balloon 4.5.
Yeah.
Yeah,
Up
and
to
Bruno,
size.
which is the
16.
pressure? 16. Okay.
16 atmosphere.
What we can do is to pull back a little
A
bit
little
and
bit. You
take,
wait before doing that.
yes, of course, and take 20.
Yeah.
There is a problem to go inside the LED, you
So
see?
it's yeah.
Okay, just a little test here now.
Okay.
I pull back my guiding.
Sorry, you are.
No, it's okay.
For this pot, you use the spider view
It's
to
okay. Yeah, the spider view
be
was
close to the
used
camera.
to avoid to have, the balloon too distal in the LED because it's a 4.5, and in order to avoid a big trauma to the LED, this was to place really the distal marker at the site of the bifurcation. Now we can come back to the other view, no problem, because you are more proximal.
Maybe we can
now.
do a Stent V's to see now maybe the difference in terms
Okay.
of size.
Yeah, very nice.
Absolutely, absolutely. So we can do the Stent V's here when you want.
Okay.
We're looking
Ready?
for the question of the audience.
I think we see clearly even here the difference in.
Yeah, we see it clearly. We'll see
Yeah.
it more.
Oh, yeah,
with
you see?
Stent
Yeah,
V's,
you see. Yeah.
Major
nice.
difference between left main and LED.
And we see also clearly the tip of the stent, which is for the moment
Yeah.
completely homogeneous. We don't see any crushing of the compression.
Sure.
Okay.
The proximal end of the stent is okay. So what you can do now, it's to remove.
Carefully.
I look, if the stent can. We have absolutely no problem here.
Yeah.
So now, next step
Next step.
we have two possibilities. The goal now is to recross the stent and place the stent through the wires in the distal circ through the stent threads. So the first possibility is to remove the LED wire and cross the threads. Second possibility, and then place the gel wire LCX, place in the LED. The other possibility is to leave these two stands like that and take a third one just in order to, place it first in LED, then we will pull back, and then we will turn the wire clockwise from the LED to the circumflex. We will turn clockwise and we will advance inside the C. It's what we try to do. So third wire.
You want to do a test, maybe?
Yeah,
Maybe
we can
to
do
see.
here. Ready?
Okay.
It's correct.
Yeah. So you have already a very good result, Jean.
Yeah, it's not too bad.
So
Yeah.
what I think some people will say, because we have
there is
no
nothing.
question again, so some people will say, okay, why not leaving it
Yeah, that's
like
the
that?
question.
That's a good question. In other words, I will tell you, many people will tell you to assess the opening of the stent, we need intracoronary imaging. It's what we heard along all the meetings, and I fully agree. It's true that if we do intracoronary imaging, what we will see? We will see that there is a difference between the angio, what we see by angiography, And what we'll see with intracoronary imaging, in other words, there will be, I'm sure, some, malapposition of the stent, particularly in LAD, in the left main. Why? Because we finished with a 4.5 balloon. And in fact, with a simple rule, when you look at the size of your circumflex, which is at least 4, maybe 4.5, plus the size of the LAD. Remember that we place a 3.5 millimeter stent, and you take the 2/3 of the sum of these two diameter, we will be close to 5 millimeter.
5.5,
absolutely.
And maybe 5.5. So that's the reason why at present time we have do the pot with a 4.5. Now we will advance the wire through the struts.
Well, yeah. But
And we will see if the wire is going easily in LAD and then doing the pullback from LAD to the bifurcation zone, turn the wire clockwise, and though dive in the circumflex, it should be okay. If we have any problem, we will move to a larger balloon for the pot, 5 millimeter. So here we are in the LAD. What I tell you, what we need to do now, we could stay in this view, which is good. We can also move to the spider, but we can try in this view because it's a large vessel. So what I will do is to pull back the wire. Bruno is ready to do the injection. And when we will arrive at the bifurcation zone here, Bruno will do a test. And now we can try by turning clockwise and pushing the wire to go inside the circumflex. So here we are. And now we have, of course, to manipulate a little bit.
Yeah.
Here we are, I think, we have closed the cells. And now we will descend again.
So Jean, can you stop here? Can you stop
Yes.
here and make an injection just to show that you are in a distal strut? because it's a case.
Yeah, I'm not sure, but what we try to do by pulling from the distality, from the lady to the left main, you have a higher chance to be in the distal strut. Okay. Are you sure? I'm not sure, but
it's not really distal, but it's mid.
I can redo it if you want. If you think that the stretch is not the right one, I pull back. Again, I pull the wire in the LAD, and we will try to do the same
in a more distal
clockwise test. And here, Bruno, we are close to the distal stroke. It takes time, but it's important.
It looks very good now.
A little bit more proximal, and it should be okay here. Okay. Here is better.
Yeah. Okay.
No, what do you think? We can take a view again.
Okay, sorry, I'm not ready.
It's better. And you see, these kind of things are very important. Again, it's like for the post-dilatation.
Yeah.
This is certainly another one.
Yeah. I like it very much. Yeah.
Okay.
Okay.
So it's a very simple
if Thierry is happy, we are happy in the lab and we can continue.
No, Jean, I think it's a perfect demonstration.
You're sure, yeah.
On how to deal with this distal strut.
Qu'est-ce qu'on a dit? 3.5 pour
3.5, ouais.
First 3.5.
Maybe you remove the gel wire?
Yeah. Now, we have this one.
You have to remember
is the right
one
wire.
Question, Jean Fayade, what kind of wire you take to recross the stent? This is the BM or another?
It's a BMW. Wire? It's the same wire. Now we remove the gel wire. Okay.
And you take care during this time to push on the other
and
wire.
I was maintaining the two other wire.
Exactly the same than the balloon.
Exactly. Exactly. Okay, here we are. So which one of
is to select the balloon. So which
what do you think? To open the struts, maybe a 3.5 and then follow by a 4?
I think we can take a 3.5.
Yeah, because to open with directly to the 4, maybe we could
here.
have...
if we take a 3.5, it could be a semi-compliant because we are close
Absolutely.
to 4.0. If you agree, because normally there is the general rule to use a non-compliant balloon in order to limit the risk of dissection because we control more the diameter of the balloon with a non-compliant. But here, because we're a little bit on the side with a 3.5, we can take a semi-compliant.
The choice of the diameter of the balloon is according to the length or the diameter of the left circumflex, or not?
True. Yes. But 3.5 is certainly too small.
Yeah.
But we take a 3.5 just in order to pre-open the struts, and then after that we will move with the 4.0. But we think that if we take the 3.5, you see, it's easy.
Yeah.
Test.
It's easy because you have done the pot.
And because we have done the pot,
you went through a distal strut. So it's usually very easy.
8-10 atmosphere. You see the size is undersized. We know that, but it's just to be to do the thing step by step. And again, in order to avoid any trauma of the left main, of the stent, etc. So this is a 3.5.
12.
Again, we are waiting for the, the deflation. Now I try to look at the weekend recross, no problem. So now what we can do is to take the 4.0
and take the 3.5
for the 15, and we can do in the same time the 3.5 for the LAD.
Yeah.
So 4.0 here, and the 3.5 for the LAD, and we will do the kissing.
Yeah. So there was maybe the question that we did not discuss a lot is because the result at the level of the ostium of the left circumflex was quite good. Do we need to reopen the struts, yes or no?
Yeah. That's a point. In other words, when we have this kind of result, and this is a question for you, Thierry, do we... No, it's important because many times we discuss, do we need to recross? This is the result after the pot. Do we need to recross and open the struts?
Yeah, I think, Jean, it's a very important question, and unfortunately we have not a final answer about that. But for many reasons, I will open the struts.
Okay.
Now we have some data that were presented at the last European Bifurcation Club meeting, showing patients at mid-term follow-up with restenosis of the ostial circ, which was not really a restenosis, but colonization by endothelial cells of the struts. So these patients are coming back because they have a new lesion, which is in fact just colonization of the struts. So I think it's one of the reasons why we should open it. Of course, there is many other reasons. One is that this patient is young, 68.
Yeah.
Maybe he will have the circ is dominant, so maybe we'll have some lesion to treat the next 10 years. And it will be easier to go through the struts which are already open. The other thing is rheology. So we know that when we leave a strut unopened in a bifurcation, the urology is not optimal. So we have areas of low shear stress opposite to the circ, which may promote neoatherosclerosis in the LAD or in the left main. So for all these reasons, I prefer to open it. But of course, we have no randomized study showing that it's better to do that. So I see that you are happy to do it also, Jean.
Right.
Yeah. We're preparing. So what I've done is to place the 4.0 millimeter balloon a little bit distal in the circ, in order to avoid the balloon itself inside the bifurcation at present time, and then I will pull back the balloon. So at present time, where is the?
So the other balloon is non-compliant or semi-compliant?
The 3.5.
3.5 is a semi-compliant.
Semi-compliant.
Okay.
But it's already used. So the one that we use.
So it's the one that we use already one time.
Ostium.
So we will try to open. I hope that we could cross. Is coming.
But we have a 7 okay.
You see the...
Now we are more coaxial.
Yeah, but I will advance again the balloon inside the circle. And now we will advance slowly the LED. Maybe the wire a little bit crossed. That's a problem. Sometimes we...
Okay,
Okay, it's not too bad here.
It's because
Okay, and now it's okay. I can pull back here. Now I will pull back the 4-0.
Not too much overlap, huh? That's
No.
It's okay like this.
What do you think here? Is okay? Thierry, what do you think? It's okay. You want to place the balloon a little bit more distantly?
I think that Thierry prefer that the two
in LED.
Maybe the two marker.
I will pull back the 4-0 more proximal just to avoid the.
So what do you want? The two marker are the same level in proximal?
No, not necessarily, because at the end you will do a final pot.
Yeah.
So I think you can pull back the 4-0.
The 4-0 we can pull back.
Just to avoid the dissection of the ostial left main.
Okay.
Ostial circ, sorry.
Okay. So we will pull back this one. Is it okay here? What do you think?
Yeah, it seems to be okay.
Okay,
too much?
No.
Okay.
Okay, here.
Here.
Ready?
Okay.
So you have which one?
I have
inflate?
The circumflex.
Yeah, you have the circumflex. And now we inflate the LED. Which pressure?
6, 8.
6, 8 on both.
Looks very nice, huh?
2.
10 on both.
10 on both.
12 on both.
So we can see that we have a nice opening of the stent at the level of the polygonal confluence.
Yeah.
And of
we
course,
can take again.
These overlap balloons will make some deformation of the stent, which will be corrected by the kissing, by the final pot. Yeah.
So now I pull back the the LED. Sorry.
Do it gently.
Then the circumflex.
And then we do the final
pot. In the same time, I push the wire.
Maybe a 5.
But now we have the guiding, which is quite coaxial, so it's okay. And now we are ready for the final pot. In other words, we will remove both.
Jean, can you just explain how you do the kiss? So for inflation, simultaneous or not, and deflation, simultaneous or not?
So what we are doing sometimes, most of the time, it's to start by the side branch in order to stabilize the balloon of the side branch, particularly if the balloon is not placed deeply in the circumflex, in the side branch. So we inflate the side branch, and when we are sure that the balloon now is fixed by the inflation, we inflate then the LED, and then we finish at the same level of inflation. It's not too high, it's around 12, no more than 14. We take, it depends, of course, of the tolerance, hemodynamic tolerance of the patient. In this case, it was very good. And we inflate 20 minutes, 20 seconds,
at least
20 seconds, 15 to 20. And then we deflate at the same time.
We try to deflate simultaneously.
Yeah. Okay, we go.
A question to my senior.
Now the 5.
Yeah.
What do you think about another technique, the pot side pot?
That's an important point.
Is
I think 0 do this
or the kissing attitude.
So Jean, do you want to answer to this question?
No, you can.
You can because
okay.
Yeah,
so I think it's a very important question.
No, it's very important. During this time, we prepare the 5 millimeter balloon.
Yeah, so pot side pot is a very nice alternative to final inflation. It was shown by the group of
On le mettra dans la orthèse.
that
12.
outside of the left main, it looks very good.
Circumflex ou
we have tried to use this technique in my center, even also for the left main, and we had the feeling that we are not able to reposition the carena in the center, because what is important with a kiss is that what you want to have is a carena in the center. This is a flow divider, so you want to have a very good rheology in both branches. And if the carena is not in the center, you will have areas of low shear stress, which may promote early restenosis.
Okay.
So that's why finally, when you have a big side branch, we prefer to do a final kiss. But I think it's a very good alternative. It's very simple. I don't know, Jean, if you use the pod side pod also in some cases or in the majority of cases. I think we need more clinical data to demonstrate that this
Yeah.
can be used for all bifurcation lesion. I think when the side branch is large, in my opinion, it seems not to be optimal. But
Yeah,
of course,
it's
we
what
have
we
not
do.
enough data.
Sometimes we are doing the majority of the time the pod side pod when we have a small side branch. Yeah.
Yeah.
Okay. The pod side
So
pod
what
is
we
small
can
branch.
do,
Okay.
it's okay, Bruno. We
Yeah.
are not too distant, sure.
No, I think it's okay.
It's okay here.
So
Yeah.
5-0,
5-0.
Non-compliant at 60.
NC up
16.
to 16. We can go to 18.
So what is the size according to the chart? Is it for 5.2, 5.3?
Yeah, I think it's a non-compliant, so it should be 5.2.
Ah, it's
I
a
think.
non-compliant. Okay.
It's a non-compliant.
NC. Yeah. So what
Okay,
you can
so
do is to
5.1.
pull back a little bit
Yeah.
to be sure that the osteum is covered. What you can see we can do is to do a stent vis
Yeah.
again to see the.
Yeah, I
You
think
see?
it would be very nice
Yeah.
to see also
Okay.
the scaffolding
I-
of the surf.
Yes. So I pull the balloon inside in order now to place the balloon for the inflate the balloon in the osteum. But we will see yeah, you see, the balloon is inside the osteum now.
Yeah.
Inside the
Yeah.
aorta.
Yeah.
It's not too bad, huh?
Yeah.
What we can do is to place maybe a little bit more distal,
Yeah,
Not too
just
much.
to see
not too much here.
Yeah.
the
Okay, go on.
osteum.
8, 10, 14, 16. Okay.
So Jean, if you can do another stent vis with the balloon a little bit more
Yeah.
distal, just to show the scaffolding of the osteum, because I see
Okay.
that there is good scaffolding because you went through the
I
distal.
will advance a little bit the balloon
If you can. Yeah.
inside here. Yeah,
Okay, I think.
slowly. Here. Stand
Yeah,
this.
perfect. Perfect.
We can.
So the
Okay, you
pods
will see
after
the stand
kissing
vis.
is very important to
Okay, look at this.
achieve
This is
Yeah, so
better now.
very
Okay,
very
so
good
very nice.
results.
So you see, Jean, clearly that you have already
The opening.
a nice opening of the strut toward the
Yeah,
circ
sure.
with a good scaffolding. So it looks very nice. Yeah.
Yeah.
Okay. So, what to do now?
I think you can remove the balloon.
Last inflation here? No.
Yeah.
No,
Yeah.
no,
So maybe-
I remove or maybe a last inflation here, just at the osteum to be sure that
And maybe you can re-advance the guiding on the balloon in order to be more selective
exactly.
and to have a nice final injection.
That's very good. That we will see. So for these things, we will open the screen like that.
Okay.
Down. 18.
18.
18 atmosphere with a 5-0. So now, what Thierry said before, it takes time to have a
Deflate,
deflation of the
Yeah.
balloon.
And you see there is no more contrast inside the balloon. It's
And now
first
what we
step
will
that you
do
need.
is to advance slowly the guiding catheter on the balloon. In the same time, I remove a little bit the balloon
So you are
in
sure
order
not,
to be more coaxial.
and not damaging the tip.
Oop, I remove the wire.
you can-
Sorry.
This one is, you can remove
the-
it, I think, because it's already stented. So
Yeah. This one. Sorry
Yeah.
for that, for this mistake, you see. So happy to have a...
Yeah,
So
sorry,
we can
because
remove it.
the
We try to place it, but
system of question is not
it's
Okay.
not working. Yeah.
no.
Okay. So it's only your question.
Yeah, absolutely.
So Adam, we are waiting for all your question.
So I will remove it. I will remove it.
Yeah, you can.
And we
remove
will
it,
do
yeah.
the final angio. And then what we could do is the question of the intracoronary imaging. What do you think?
Yeah, of
First
course.
the angio. According
Yeah.
to the angio, we will see.
See.
Absolutely.
Normally we are not doing systematic.
Normally in routine we are not doing, but in this particular anatomy it's so So difference of diameter between the left main circumflex and LAD, that
Very
maybe
nice,
we
huh?
need.
We want to control we are inside the left main stent.
Yeah.
The result at the
Yeah.
level of the left main is very
Yeah,
nice.
it's
The
very good,
osteomy is
yeah.
very nice. Maybe we can check the distal LED, the mid
Yeah.
LED,
Okay.
Absolutely. So I
because it's the
think
only.
the left main and proximal LED, proximal circ is perfect with the
Here
one
we
stent
are.
technique. Then,
Ready?
of course, we have this problem of the mid LED, which was a little
But I think it's
diseased.
stable.
It's correct.
There
Absolutely.
is
So
this.
it's as it
No,
was
it's
at the very
okay.
beginning.
Yeah,
Yeah,
it's a long disease. And
it's
if
a
you
long
want to
disease.
stent the mid, then you have the distal plaque also. So
The left main is good, huh?
yeah,
Yeah.
Again, the other view.
and
Correct. Huh?
zoom.
So
Oh,
unfortunately, we have
It's
no
correct. Huh?
question because of connection problems. I don't know
Okay, no
what
problem.
we have. But I think, Jean, you have done a great job with a very nice learning
Vous l'avez sorti le truc,
case.
on peut le faire.
ouais,
Alors.
non, mais sinon c'est pas grave.
So of
Okay.
course we can discuss about intracorner imaging. So what is your opinion? In this case, should we do it during the procedure, after stenting, or
So,
only when you think that there is something which is going wrong or something not clear?
so that's the last view in the in spider view, and
The result is quite nice. Huh?
the result is nice.
I would
Yeah.
say it's perfect for me.
Yeah, remember, we start from here. I will show you. That was the beginning.
Yeah.
And that was this the result now. I think it's okay.
Yeah.
We can eventually
do
do
an OCT recording from
an
the
OCT
circumflex.
pull back from the circumflex to the left
To be
main.
sure that
to see. What do you
the
think?
position of the left main.
Yeah,
is
to be
correct.
sure of that position, because okay, it was 5 millimeter in the left main, 3.5 in LAD, 4 millimeter
Yeah.
in the circumflex. Now, what we can do, because of this particular anatomy, is to be sure that the selection of this balloon was the right selection, in order to be sure that we have a correct
A position
and
of the
optimal
stent.
position of the stent on the wall, on the left main of on the left main and LAD. So
Regarding the initial question of Thierry about when do we use intracoronary imaging, in our cath lab we are using it very
very
rarely,
few, very
and
few.
it's probably only at the final angio when we have any doubt about the result.
Exactly.
At this moment we will do a control. I think in my experience I don't remember to have used it before starting the procedure because we have our strategy already decided.
Yeah.
At the end, not systematically, and only if we have any doubt about the good quality of the angiographic result.
Yeah, I fully agree with you. We are doing exactly the same in my lab. So will you use OFD, OCT? Okay.
Yeah.
So I think what is important for the left main is the amount of contrast that you are injecting in order to have
Yeah.
a perfect view.
Exactly.
And in my lab, we are following the recommendation of Pascal Motreff,
Yeah.
who said that we should use the size of the left main plus 1 cc. So it should be 6 cc per second.
Yeah.
Okay, because you
To
mean
be
an
sure that
automatic
you have, yeah,
with an automatic control. Yeah.
absolutely.
So what we try now is to advance, but
So
I
not
have some
4.5
difficulty.
or 5, but 6.
I have some difficulty to advance I don't want to destroy
Yeah, of course.
what we have done. So I have to manipulate the guiding catheter
Okay, now
in order to be more coaxial.
and it's very gentle.
The most important is to do the thing gently.
And you
Yeah, of
see,
Never forcing, gently. So, and what I'm doing, I pull the wire
yeah,
and I advance simultaneously the wire
mettre un
and
injecteur ou pas?
the OCT catheter. Sometimes it's
Bon, c'est bon.
It's not easy in this particular case. Don't want to be too okay. It's coming.
Qu'est-ce qu'il y a?
It's perfect.
Qu'est-ce qu'il y a? Il y a un message.
What
There
is the
an
message
error
error?
message.
Question
Oh, say
to
sorry.
Thierry.
Yeah.
Generally, in your practice for the left main
Ils disent qu'il y a un message
imaging,
d'erreur.
you
Sur
prefer
quoi? Sur
IVUS
Sur
OCT?
or
l'OCT?
OCT? What is the best?
So today we are using mainly OCT
Pourquoi?
or FDI
On peut pas
because
là.
we are more comfortable with this
Parce
kind
que là,
of
je suis au fond, ça m'a
images,
pris.
even for the left man.
Voilà.
Even for the left main.
Yeah.
Okay.
Attendez.
So it depends also if the renal function of the
Yeah,
patient is normal or not,
Voilà.
because sometimes you have you may have a patient with poor renal function, so you have some limitation with
Use of contrast.
OCT. Yeah.
Okay. You have some problem with the device. Okay.
Ah.
Montrez le cathéter,
Okay.
l'OCT. Il faut voir ceci.
Okay.
Ok.
Ok. So I will...
Mettez-le en grand, hein. C'est plus important que l'angio là. On est pas mal, hein. Qu'est-ce que tu en penses?
Ouais.
Ouais.
Je peux
Perfect.
peut-être retirer à peine un poil. Qu'est-ce que tu en penses?
Ouais, c'est pas mal.
Ouais, ici.
Ok.
Voilà. Ça te va? Bon, on va essayer.
So it will be a manual injection, so I'm not sure that I will achieve the C.
Yeah.
So we'll
Ah,
You
yeah.
are here? I am okay.
But you are strong enough to do it, huh?
Yeah.
Yeah.
Let's see.
It's,
Not
it's
sure.
what I'm working with Bruno. He has the power of the injector.
Ok. Are you ready?
I'm ready.
Activez le retrait, c'est bon? Ah, purée.
Excellent.
Very good.
But for sure, I agree with you, Thierry. The quality of the injection is much better when you use an automatic injection with
Okay, so it's very quick, but we have seen, you see this vessel is very large.
And let's see.
Ah,
Oh,
it's
yeah,
very
it's
nice,
okay.
huh?
Huh? It looks okay, huh?
It's very nice, yeah.
It
Yeah.
looks okay.
And
What we can do is to remove and then we will look
I will let, yeah.
at the images.
So a position
I cannot remove it. I
of
cannot
the
remove
stent
it.
at the ostium is very nice.
Yeah,
Yeah.
we don't see any...
And
no
on the
dissection.
left man also, it looks very nice. Huh? Okay.
Yeah, we don't see any...
It's very nice.
Yeah. No, I think when we look at the first last millimeter of the quality
Yes.
of the apposition is quite nice.
Yeah.
Yeah.
Absolutely. And then we see a little bit on the long view the ostium of the
Yeah.
LED.
of the circ also, which is of the LED, sorry, which is
Yeah.
very nice too. Yeah.
Yeah.
Can we see the LED? Go to the bifurcation.
Okay. From one question,
Qui c'est
why
qui
do
l'a-
you choose
Qui c'est qui le fait là?
the
C'est bon.
OCT
Hein?
to the left main to same
Okay.
compress?
Go
Okay,
on.
we can choose
We
Of
do
course, you
it
can do
both.
both,
from
but
main to
Vas-y.
late.
but the objective of Jean was to show that the stent is fully apposed in the left main,
Yes.
Yeah.
that the ostium of the circ is okay without
Okay.
dissection.
Encore.
Encore. Encore. We go to the bifurcation.
Yeah.
Encore.
Okay.
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 Look,
Okay.
Okay. So
look
now we
at
see
the opening. Yeah.
the opening of the circ, which
Yeah.
is perfect, with
Yeah.
no strut in front of the circ.
Yeah.
So it means that you have done something
Yeah.
perfect. You went through a
Absolutely.
distal strut, and
Okay.
you have very nice position of the stent everywhere,
Yeah.
including the ostium of the circ.
Yeah.
So
Okay.
it's a great result, Jean.
Yeah. So what you can do is to do the last angio
Okay.
after this manipulation of the intracoronary of OCT catheter inside the left main, in order to be sure that everything is fine, particularly during the removal. Beautiful. I think we
It's
can
good.
stop the procedure at that point.
Yeah, I agree.
Okay. And we can zoom on it.
Yeah.
Okay,
Good.
so that's I think the final result that we
Yeah.
can accept, and geographically
The
we have
result.
a very good result, and
Yeah.
we check by OCT,
Yeah.
and again to tell you that is not what we are doing in routine, but in this particular anatomy, because of this particular difference in sizing between the LED, the proximal LED, the proximal circ, and the left main, I think that it was important to verify that the strategy that we had
Yeah.
concerning the selection of the balloon, 3.5 in LED, 4 in the circumflex, and finishing by 5 millimeter high pressure for the last spot in the left main, was the right strategy in order to give to this particular patient the best result and geography, bio-CT, and hemodynamically.
Yeah,
Okay,
it's
so
clear.
now what we
So,
have to do is to just remove the 7 French guiding,
so Jean,
and we will join you in few seconds. Yeah.
can you tell us about the DAPT? Because we have still no questions, so we maybe close the session now.
Yeah.
So concerning the APT,
How much
this
time?
patient was already pre-treated with a combination of aspirin and Plavix. Concerning the dose of aspirin, it was 100 milligram daily, using the aspirin Protect 101 pill per day. Concerning the clopidogrel, it's a 75 milligram tablet per day. So that's the current management. So now for the next month, we will continue, Bruno, this association for 6 months.
At least 6 months. It's
Yeah.
only one stent provisional strategy. It was a stable patient, so probably 6 months could be enough.
Yeah,
But
no-
if the patient tolerates well this
Yeah,
DAPT
why not
protocol,
1 year, 2 or
yeah,
12 months?
1
Because
year.
in this particular patient, there is no risk
no.
at present time, no risk from bleeding complication.
So I think that the
So-
recommendation would be 6 months, and if possible 1 year,
Yeah.
if the patient tolerates weight and has no bleeding
Yeah.
complication.
And again, particularly in this particular patient, it's left dominant circumflex artery. You saw the picture of the right, which is very small. So we need to give to this patient the better chance for the good long-term outcome.
Okay, perfect. Thank you very much, Jean. I think it's time
Okay.
to conclude. So we'd like to thank the attendees, even if they were not able to ask questions. We try to do our best to answer in advance to the question that they may have. It's very important also to conclude that next year
C'est fini, monsieur.
we'll
Attendez. Hein.
build for you a similar continuum with 6 webinars, which will be prepared by Goran Stankovic. I will show a nice end of the year and hope to see you next year. Thank you.
Thank you.